All right, so a couple disclosures you've seen before. So the debate, we have the leading candidate, cross, so very cross. The second candidate is engaged in a certain kind of thinking. And then, of course, the scatologic approach. So, thank you. So I think, it's good to go back to the beginning. Oh, first of all, I want to thank Dr. Grothe and his colleague, Dr. Hallemeyer, for providing many of these slides, the blue slides from their previous presentation on this. But I think to start out, we should really go back to the Hershkovich regimen, a very underpowered study, but looking back at radiation combined to chemoradiation. And as you can see here, we have a statistical effect, even though it's a pretty small trial, on reducing local recurrence, distant metastases, and improving overall survival. So, I think that is kind of a basic approach, and even though it's an old study, kind of the bottom line. And then, of course, I think a study that most of us rely on today is the cross study from the Dutch cross study of esophagectomy compared with preoperative chemoradiation using carboplatin and Taxol. And in this study, the 5-year survival was substantially better with neoadjuvant chemoradiation. However, I think we should pay attention to the fact that the effect was much more pronounced on the squamous cells compared to the adenocarcinomas, which were barely statistically significant and much less of an effect. And especially in my institution, the surgeons don't really see the difference, and they want everybody to be treated with the cross regimen. So the toxicity was pretty acceptable in the combined modality arm. And as you can see here, the R0 resection rate, the node positivity rate, and the PCR rate was really quite improved with preoperative chemoradiation. And when they combined their phase 2 and 3 studies to give it a little bit more power, you can see here that there was a statistically significant reduction in local regional peritoneal and distant metastases as well. So if looking across several trials with neoadjuvant chemoradiation, Walsh's study, the CLGB study, and the CROSS study, we can see here that preoperative chemoradiation is better than surgery alone. However, we really still don't have any definitive studies about the role of radiation. And also, I just wanted to point out here, no anthracycline. That's for the next debate, though. So then that brings us to the MAGIC trial. And of course, this is for all adenocarcinomas, but included 25% distal esophageal and GE junction. So this is not just gastric cancer. And this had perioperative chemotherapy with ECF with very similar improvement in 5-year survival compared to surgery alone, with the somewhat less impressive PCR and R0 rates compared to chemoradiation, but nonetheless apparently as similar benefit to chemoradiation with just perioperative chemotherapy alone, a triplet. And in this trial that was published in JCO in 2009, there were only 119 patients enrolled because it was closed prematurely. Nonetheless, there seemed to be a benefit of additional chemotherapy with chemoradiation preoperatively. And you can see here that there was an improvement in the clearing the nodes in the PCR rate with radiation. So a meta-analysis of several of these trials together have tended to show that chemo-RT versus surgery and chemotherapy alone do benefit compared to surgery, but chemo-RT compared to chemotherapy is still a bit of a question. The hazard ratio is a little bit favorable, but there is less power because there are fewer trials that have really answered the question of what's the role of radiation. And so that brings us to the the MCRC, the British studies of esophageal cancer, OE02, and of course that's because in Britain they always have to throw an extra O in. I'm not sure why, but there you are. So chemo followed by esophagectomy compared to esophagectomy alone in the first trial, and in this trial they used just 5-FU cisplatin, and you can see here that 2-year survival was 43% versus 34% with induction chemotherapy. And these were statistically significant, but because of the subgroups being smaller, neither for the adeno or the squamous did you tend to see a statistically significant difference due to a smaller sample size, but the effect is more pronounced for the squamous as well. And that kind of brings us to the latest study from the MCRC, the esophageal 5 trial that David Cunningham presented this year. And in this trial, it kind of built on the O2 study, looking at the 2 cycles of CF compared to 4 cycles of ECX, so a triplet upfront followed by surgery alone. And this was quite an ambitious study, attempting to enroll 1,300 patients, which would have given a lot more power to detect a small difference, but then was revised to only 850 patients, which is still quite impressive. And they did accrue the trial, and you can see here that the ECX toxicity was higher, except for stomatitis with the CF regimen. And in terms of the surgery, it seems like a fairly equal number of patients got to surgery. You can see here that out of 40 patients who didn't, 37 out of the 40 were inoperable because of progression, and that was really not very different for the ECX arm, 44 out of 59. And then for the patients who did go to resection, those who had actually got to surgery, 94% in both groups did actually undergo resection. So about 94% of 90% got completely resected. If you look at the pathology and the pathologic response rate, the ECX arm did have a somewhat higher pathologic response and a little bit higher R0 rate, but it wasn't statistically significant. And the PFS was a little higher for ECX, but did not make statistical significance. And these are in years, so 1 3/4 years versus 1.53 years for the median time to progression. The overall survival, however, was really not different with a hazard ratio of 0.92. So in the end, giving 4 cycles of a more toxic chemotherapy did not really benefit. And the 3-year survival, which was the primary endpoint, was really only 3% apart, and that was not statistically different, but they are showing that compared to the prior OE02 study, the control arm did much better too. I don't know what that means, except that you can't use historical controls when you do these kind of studies, and we still need to do randomized studies even with the same control arm. Things can change with better preoperative staging and so forth. So, and no subgroup really benefited more with the ECX compared to the CF. So in conclusion, neoadjuvant chemotherapy outcomes are superior to surgery alone. Neoadjuvant chemoradiation are also superior to surgery alone, but it is still hard to determine the role of radiation per se. I don't think that this is a definite standard of care that needs to be used in every case of adenocarcinoma of the distal esophagus and GE junction. And we do know finally from the 05 study, which is a very large and well-powered study, that more chemotherapy does not really seem to benefit. Giving more cycles of more toxic chemotherapy is really not superior. And with that, thank you.